Dear friends, it's my great pleasure once again to welcome Dr. Pathophysiology, the proverbial endocrinologist from the city of Calcutta, the MD, DM endocrinology, DNB endocrinology, and very highly qualified, academically very rich, and clinically very astute, and research-wise very interested in serving the various problems in our country in the field of diabetes, in the field of adrenals, and in the field of diabetes in the young. Therefore, over to Dr. Parthopratim.
So, what we are going to discuss today is that the challenges we face in managing type 2 diabetes in India. Now, we all know that Indians, rather the Southeast Asians with type 2 diabetes, are a bit different from our Caucasian counterparts for a number of reasons. Number one, we all know the thrifty genes and the thrifty phenotypes. So, from a genetic perspective, we are more prone to develop type 2 diabetes. Apart from that, we Indians are non-obese. Even if we are non-obese, we have more visceral fat, and amongst other individuals with more visceral fats, we have more unhealthy fats. So meaning thereby, despite being non-obese, we are more prone to develop diabetes because of the unhealthy lipids we have. In addition, Indians are more prone to develop the diabetic complications, macrovascular to be more specific, and there are evidences that microvascular complications are also common and appears early in individuals with type 2 diabetes residing in India. To cut a very long story short, we Indians develop diabetes early, about 10 years earlier than our Caucasian counterparts, and we have more complications which are more severe and once again develop on the earlier part of the disease. So with this background, let's go through my presentation that will be dealing with challenges and possible solution of managing type 2 diabetes in India. Now, this has been taken from the recent IDF Atlas, the 10th edition of IDF Atlas published in 2021. Now, if you focus on the map on the upper part of the slide, the areas colored in black have the highest prevalence of type 2 diabetes in 2021. That includes India, China, Pakistan, and USA. Now, if you concentrate on the table, that gives you the exact number of people having type 2 diabetes between 20 to 79 years of age. Right now, India is having 74.2 millions of diabetes, and which is expected to be around 125 millions in 2045. This is the reason we are focusing on the issues and challenges of type 2 diabetes in Indian populations. Now, we all know about the HbA1c targets. Overall, for a so-called garden variety of type 2 diabetes, in majority of our patients, we target a A1C of 7% laid down by the American Diabetes Association. Now, there are other guidelines. For example, we have a AAC-EACA target of a more stringent cutoff of 6.5. However, for all practical purposes, we focus on a A1C of 7%. Having said that, this is not a watertight figure. Those with long-standing type 2 diabetes, with limited life expectancies, more target organ damages, history of recurrent hypoglycemia, the glycemic target has to be relaxed. On the contrary, those with young onset type 2 diabetes having more life expectancy, a prolonged life expectancy, no target organ damage, we have to target a A1C of around 6 to 6.5. Now, if we look at the value of A1C across the world, despite the so-called claim of improvement in diabetes care, almost half of our patients with type 2 diabetes do not achieve a A1C target of 7%. So meaning thereby, overall, if you look at the global data, we are doing not very good. Focusing on India, the figures are even dismal. And this has not changed over the last 10 years or so. For an example, in 2011, the mean A1C in diabetic population of India was around 8.9 and less than 20%. Yes, I repeat, less than 1/5 of our patients with type 2 diabetes achieve a A1C of 7%. Coming to a 2013 study, the Achieve study, once again, the mean A1C was 9.2. Now, in 2019, once again, if you look at the figure, almost a quarter of our patients reach A1C target of less than 7 as evidence from the TIDE study. However, there is some improvement in diabetes care. There is a silver line. If you look at the recent publication of the ICMR in Diab 13, about 36.3% of those with type 2 diabetes in India achieve a A1C of 7%. So meaning thereby we are doing poor, but once again, there is a silver lining that the recent data suggests that compared to the past, we are doing somewhat better in at least 2020 or 2021. So here lies the importance of identifying the challenges in management of type 2 diabetes in India and to find the solutions of those features. Now, so what are the challenges we face in a routine day-to-day practice? Now, the most important part would be the lack of education for our patients. We have to improve the basic educations of our patients as far as the disease is concerned. You know, it's a lifelong disease. So they have to know the disease they are suffering from, and they have to know how to manage the different complications, be it acute and be it chronic. The other part we face that's applicable to all the third world countries is the absence of a structured care delivery. We have to train physicians, the primary care physicians, and we have to provide a structured health service to the populations. And once again, diabetes is not a disease of a blood glucose level. It's a disease, it's a metabolic disease. There are numerous macrovascular and microvascular complications of diabetes. So managing blood glucose level won't be sufficient. We have to manage the different macrovascular and microvascular complications of diabetes along with glycemic control. Now, we all know about the UKPDS data, the study that kind of changed the entire perspective of management of type 2 diabetes. They highlighted the importance of strict glycemic control, and not only strict glycemic control, strict and early glycemic control. They have shown that if you can achieve a A1C of around 7%, or in fact, if you can lower down the A1C by 1%, you can gain significant benefit as far as reduction of microvascular complications of concern. Microvascular concern. However, not only microvascular complications, on the long term, reduction of A1C also provide an improvement in the macrovascular complications as well. So as I have told earlier, that it's mandatory that you have to individualize your glycemic targets depending on age of the patient, depending on the life expectancy of the patients, depending on the underlying target organ damage and the associated comorbid conditions. Now, what are the barriers? As I have said, you have to take into account all the possible barriers, starting from the physician's perspective, from the pharmaceutical perspective, and from the patient's perspective. Now, as it's a lifelong disease, most of the people are stressed about the disease. There is a term that has been recently coined as the diabetic stress. So we have to educate the patient, we have to take them into confidence, and we have to counsel them to allay these psychological aspects of diabetes. In majority of our cases, they come from the rural areas. Now, once again, managing a patient coming from a rural background is really difficult, not only because of lack of literacy, not only because of poor socioeconomic strata, but because of different misbeliefs, superstitions, and particularly for those being treated with insulin, there are issues related to insulin storage and so on. However, this can all be overcome with appropriate counselings, and as I have said, by providing a structured healthcare facility to our patients. Now, diabetes, type 2 diabetes to be more specific, it does not develop overnight. We, as endocrinologists, divide individuals in three subgroups. One, those who are normal, those with pre-diabetes, and those with diabetes. Now, diabetes, as you all know, is defined by a fasting plasma glucose of at least 126 milligrams per DL or more, or a post-meal plasma glucose of, rather post-glucose plasma glucose of at least 200 milligrams per DL or more, or a A1C of at least 6.5% or more. Now, there are some people who does not fulfill the criteria of diabetes, but also their glycemic profile does not fit into a normal phenotype. For an example, those with a fasting plasma glucose of 100 to 125 milligrams per DL, or those with a post-load plasma glucose between 140 to 199 milligrams per DL, or a A1C of between 5.7 to 6.4, they do not classify the diagnostic criteria, or they do not fulfill the diagnostic criteria of type 2 diabetes, and they are not normal. They are classified as pre-diabetes. So pre-diabetes comprises of impaired fasting plasma glucose, that is fasting plasma glucose between 100 to 125 milligrams per DL, or an impaired glucose tolerance, that is a post-load plasma glucose of 140 to 199 milligrams per DL. Now, these are forerunners of type 2 diabetes, and they have higher cardiovascular risk like those with diabetes. Now, this gives us an opportunity. If we can intervene early in the pre-diabetes range, we can delay the onset of type 2 diabetes. So we have to intervene if possible, if the disease is diagnosed at the pre-diabetes stage. Now, how do we intervene? How do we delay the development of diabetes in those with pre-diabetes? There are numerous studies. However, the focus would be on lifestyle modification, meaning thereby a healthy diet and a physical activity. Healthy diet meaning there is nothing called a diabetic diet. So we have to calculate the required amount of calorie depending on the patient's age, body weight, height, and the physical activity level. Those with obesity should cut down their daily calorie intake, and those with lean body habitus or those with having kind of a active lifestyle, they can be allowed relatively higher calorie intake. So diet would be the first line management to prevent diabetes in pre-diabetes. And the second is regular physical activity. What do we mean by that is that at least 150 minutes of brisk walking every week, and there for at least 5 days a week, meaning thereby we need to advise all our patients to undergo brisk walking daily for 30 minutes, if possible, every day. So this is the most important aspect of preventing type 2 diabetes. Now, there are different drugs that have been tried to prevent diabetes in these particular subgroups, and they have proven benefit to prevent type 2 diabetes. The drugs are metformin. The drugs is orlistat, which is a pancreatic lipase inhibitor commonly used as anti-obesity agents. A alpha glucosidase inhibitor, that is acarbose. Another insulin sensitizer, that is pioglitazone. And the costliest or among these agents is the liraglutide or a GLP-1 receptor agonist. These are the agents which have shown benefits as far as delaying development of type 2 diabetes is concerned in pre-diabetes patients. Having said that, I would once again highlight the importance of lifestyle modification to delay diabetes. Now, those who are morbidly obese, for an example, those with a BMI of more than 27, having one or more comorbidities, or a BMI of more than 30, more than 35 particularly, they can be subjected to bariatric surgery, and reduction in body weight can also help to prevent type 2 diabetes. Now learn that at present, only 36% of our patients in India with type 2 diabetes achieve a target of A1C. And why is that happening? Now, there are studies which looked into the compliance factor of our patients. Not only non-compliance is a contributing factor to this poor control of diabetes, there are other issues. For an example, if we look at the pathophysiology of type 2 diabetes, it is not that simple. During our training period, we were taught that pathophysiology of type 2 diabetes is quite simple. On one hand, you have insulin secretory defect. On the other hand, you have insulin resistance at the level of the liver, insulin resistance at the level of periphery, and you have type 2 diabetes. But now we know that pathophysiology of type 2 diabetes is multifactorial and perhaps yet to be crystallized. We now know of ominous octet, and people has gone beyond ominous octet. They have coined terms like dirty dozens of diabetes, treacherous 13s of diabetes, faithless 14 of diabetes, and so on. So perhaps even in 2022, we do not know the exact pathophysiology of type 2 diabetes. So that is one aspect. And the other aspect is non-compliance. And what are the etiologies of non-compliance? If you look at this particular study done in my state, that was forgetfulness, financial constraints, and the number of medications. Those are the dominant etiologies of non-compliance in India. Figures are not different even in southern part of the country. Once again, in that study, if you look at the line highlighted in red, only 16.6% were adherent to the prescribed anti-diabetic drugs. And once again, the major reasons for non-compliance were cost and multiple dosing. So we have to address the non-compliance, and we have to understand the important factors contributing to non-compliance in India. That is number one, cost, and number one, the pill count. Now, this issue is not confined to India. Surprisingly, this was taken from US Today in 2019. Even people from Canada, from Mexico, they have to supply the insulin to their friends and colleagues in US, because people living in USA are also struggling with to procure insulin in their country as well. So this is one part. We have to cut down the cost of therapy. And recently, molecules like dapagliflozin, molecules like sitagliptin are being offered at a relatively cheaper cost. So that will definitely help to achieve the A1C target in our patient populations. The second important issue was the number of pills. So we can and we have to reduce the pill burden by using a combination therapy. Now, combination therapy is not a new concept. Majority of us, if not all, use fixed dose combinations of different available anti-diabetic agents. So that can definitely help us to improve the compliance and thus help us to achieve the A1C target. So prescribing a fixed dose combination helps in increasing adherence to therapy. It improves patient satisfaction, lowers medical cost, and of course, lower A1C. So what are the, as I have said, that the pathophysiology of type 2 diabetes is multifactorial. So we have to target the different aspects of the pathophysiology of type 2 diabetes. The most important model in pathophysiology of type 2 diabetes is the differentiose ominous octet model. So we have to target the insulin secretory defect that can be achieved by giving a sulfonylurea or a meglitinide like repaglinide or nataglinide, or a gliptins like the sitagliptin, the linagliptin, the alogliptin, the vildagliptin, the evogliptin, the teneligliptin. We have so many gliptins in market. Now, the basic advantage of using gliptins over sulfonylureas or meglitinides, that is nataglinide or repaglinide, is that the gliptins, they stimulate insulin secretion in a glucose dependent manner, meaning thereby if the plasma glucose is high, then and only then a gliptin stimulates insulin secretion. So the chance of hypoglycemia is almost nil with the DPP-4 inhibitors. So they are considered more as anti-hyperglycemic agents rather than hypoglycemic agents. If we need to address the insulin resistance, we have drugs like metformin, like thiazolidinediones, that is pioglitazone. We know that there is hyperglucagonemia in type 2 diabetes. Once again, by giving a gliptin or a GLP-1 receptor agonist, we can address that hyperglucagonemia of differentiose ominous octet. Now, the renal contribution of systemic hyperglycemia can be taken care of by giving a SGLT2 inhibitors. So a combination of a gliptin or a GLP-1 receptor agonist along with a gliflozins, that is SGLT2 inhibitors, with metformin or pioglitazone, with or without sulfonylureas, can address the different arms of differentiose ominous octet and helps us to achieve the A1C target in our patient populations. Now, I have discussed the importance of early initiation of combination therapy. Now, if we look at the recent data, there was a trial known as verified trial that used a combination of gliptin and metformin in those with A1C as low as 6.5%. And they showed that early combination can delay the addition of a third agent in those being treated with that particular combinations. The advantage of using this combination is that a gliptin and metformin, as I have said, are not associated with hypoglycemia. So early in the disease, we have to intervene, possibly with multiple agents, which are not known to cause hypoglycemia. So this message has to be clear. Start early a combination of a gliptin or metformin, or a combination of gliptin and a gliflozin, or a combination of gliflozin and metformin in your patients to achieve early glycemic control. That will help in the long run to reduce both the microvascular and macrovascular complications. Now, beyond the glycemic control, you need to target the elevated blood pressure. The target in majority of our patients should be less than 130 by 80 millimeter of mercury. Statin is almost universal after 40 years of age, so you have to take care of that. And those with established atherosclerotic cardiovascular disease or a chronic kidney disease or history of hospitalization for heart failure, we have data favoring use of GLP-1 receptor agonist or SGLT2 inhibitors as far as these complications are concerned. Now, once again, I have highlighted the importance of patient education and patient empowerment. You have to teach not only the patient, but also his or her relatives, and it has to be a group management kind of thing. You alone may not be sufficient to provide adequate care to your patients with type 2 diabetes. Awareness is of utmost importance, and the importance of awareness cannot be overemphasized, and it has to be done at a community level, at a baseline level. Now, in the recent past, during the COVID pandemic, we have understood, we have realized the importance of telemedicine. So that can also be utilized in our patient populations. For an example, people are now taking photographs, the retinal photographs in remote areas, and are uploading those photographs and getting opinion from the specialist sitting in a distant away from that particular patient. The help of technology can be utilized, and telemedicine strategies can also be utilized to treat our patients. So the solutions to overcome the barriers, the possible solutions are improvement in patient educations. We have to train physicians, those who are willing to serve at grassroots levels. They need to know the management principles of type 2 diabetes. In the past, we used to tell that if you know HIV, you know medicine. Now we know if you know diabetes, you know medicines. We have to hit early and we have to hit hard, like that in rheumatoid arthritis. We have to choose agents that target multiple pathophysiology of type 2 diabetes. We need to provide prescriptions containing the best possible simplified treatment regime. We have to try our best. We have to utilize the fixed dose combinations to reduce pill count as far as possible. Reduction in treatment cost is not in our hand, but having said that, now we have molecules like dapagliflozin, like sitagliptin, like vildagliptin at a much cheaper cost, and the importance of monitoring the monitoring our blood pressure at every visit, monitoring renal function like serum creatinine, the urine ACR every yearly, if not every 3 or 6 monthly, particularly those having underlying chronic kidney disease, a retinal checkup every yearly. This has to be there in the prescription. So with this, I end my talk. Thank you very much for your listening.
Your presentation has been superb. So let us start the discussion right away. Uh, what do you think are the real challenges that an Indian diabetic faces today, Dr. Parthy?
So that I have already discussed. Number one is the huge population of type 2 diabetes in India. Number two is the early onset of the disease. We Indians develop diabetes about a decade earlier than our Caucasian counterparts. We develop complications, both the microvascular and the macrovascular complications early in the course of the disease. Many of them have those florid complications even at the disease onset. We have more of an unhealthy fat despite having low or a low normal BMI. And we have issues related to compliance, related to cost of therapy, related to quality of health care. The doctor is to patient, this huge chunk of individuals with type 2 diabetes. And more importantly, perhaps we need trained physicians who are willing to serve at the community level, at the grassroots level. So these are the areas that needs to be highlighted.
You did speak about Professor Partho regarding the patient's awareness and patient's education being one of the most important aspects of Indian diabetics, where we score very low. And possibly, therefore, our patient awareness program, the patients being posted with the disease is very low. They are not very well posted with what's going to happen in the field of diabetes. The diabetics who know maximum win the disease. And do you think that the basic education, as you showed in your slide, is very low? And tell us the ways and means that you have already spoken about it, but a clinical, practical outline, some focus points where you can take it forward about the patient awareness, patient education regarding diabetes.
So once again, sir, if we have to serve a lot of people at least in government hospitals. For an example, there is a long queue of patients in every diabetes OPD, at least in my hospital. And it's very difficult to spend times with patient educations in those busy OPDs. Even if you look at the non-government scenarios, probably we don't have that time, to discuss all the issues, to make them about the disease, its complications, the utility of food care, the routine checkups, and so on. So I think we need some diabetic educators. They are willing to work at the grassroots level. They can take it forward, all the patient educations, awareness. In fact, in the government of West Bengal is running a course on diabetic educators. I think we need more of a diabetic educators and some trained physicians, maybe MBBS, maybe MD, but they're willing to serve in a proper way, in a grassroots level. So these are the two issues that need to be highlighted.
Okay. Are you aware of any program that is running in our country regarding the Indian Diabetic Education Program, IDEP, Dr. Partho?
Sir, RSSDI is doing some job. They have done district coordinators. They are doing it in their own way. The government of India is also, government of West Bengal, at least I know of, is doing also some of a bit. So there are different private organizations. They are doing at their private levels. These are the issues, the programs I'm aware of.
Okay. I just wanted to know that, do you think that a diabetes specialist nurse program, a nurse educator who specializes only in diabetes education and becomes the key fulcrum of the diabetic department in any institute will be of great help, Partho?
Definitely, sir. For a number of reasons. As I have told that we need diabetes educators. Similarly, nurses, no, in majority of our patients, they do not know how to inject insulin. The way of storage of insulin, the proper way of, that drawing up insulin, particularly if the regimes are somewhat complicated, how to store insulin, the regular rotation of the injection sites to avoid injection site reactions like lipoatrophy, hypertrophy, infections. The food care, that is a part which is grossly neglected in our patients. The importance of food care, that these are to be highlighted by a diabetes educator or a diabetic nurse. So there is no doubt about that. We need those individuals to work at the grassroots level.
Yeah. And as you rightly said, Professor Partho, that a doctor is not able to provide because of this, his call for duty, not that he doesn't want to give. He doesn't provide between 2.5 to 3 minutes to his patients because of a large number of patients and less number of doctors. This was also shown in the Impact India study. Now, do you think that some of the roles of the doctors, which can be delegated to a supervised list of jobs to be done by the diabetes specialist nurses?
So once again, as I have told you, we need some dedicated physicians. They need not be endocrinologists. They need not be highly qualified. They should have the basic knowledge of managing type 2 diabetes. And as I have said, glimepiride, metformin, pioglitazone, and teneligliptin. These are being supplied by the government of West Bengal. These are enough to control blood glucose in our majority of our patients. So they need to know the basic principles of diabetes management, and more importantly, they have to be dedicated. So they can supervise those trained educators, those nurses, and can offer a significant improvement in diabetic education, diabetic management in India. There is no doubt about that.
Yeah, I just wanted to know, in a complementary to the patient education, do you think there is also a need for continuing improvement in the knowledge base, academic clinical knowledge, and practice skills or practice essentials for the healthcare providers also? If so, at what level you want to give this reinforcement in the doctor's education?
Definitely, sir. Definitely. So, medicine is an ever-changing subject. So, you have to accept those changes and you have to be updated. So, and it has to be done at every level. If you look at the ADA EASD guideline, majority of us, particularly the physicians, they follow that particular guideline. Look at the change. Every year there is some kind of change in that algorithm. So it has to be there. The importance of continued medical educations, updations cannot be overemphasized, and it has to be done at every level. Some of the trained endocrinologists, they may take up classes of those physicians. So it has to be done at every level, not only at the level of the grassroots workers, but also for us, maybe sitting at the highest level of the diabetes care.
Yeah, I just wanted to know that, as you rightly pointed out, that in our country, the combination therapy has come to stay. And as you rightly said, these 4 drugs, metformin, glimepiride, one of the sulfonylureas, pioglitazone, and the other one you said, fourth one?
So, as because the teneligliptin was the cheapest, so that's why I mentioned teneligliptin. Now probably that is not an issue, because we have to address the cost of therapy as well.
So the drugs that can use maximum in our country centers around metformin, sulfonylurea, gliptins, and SGLT2. And as you rightly pointed out today, Dr. Partho, all these drugs have become, the barrier of pricing has been broken. And the generics are available at a cost which is very affordable. And I call it that they're very affordable. They're very appropriate because, this drug, gliptin and the SGLT2 inhibitor, they together address about 6 of the 8 amino octet of the frangio. If you take sulfonylurea and metformin, and that addresses about at least 4 of these ominous octet. And if you add pioglitazone to it, it takes 1 or 2 more extra. So therefore, these drugs are quite potent to address the Indian population with type 2 diabetics. I just wanted to know from you that what are the ways that Indian diabetes in the young is different. You already spoke to that in your slide presentation, but to make it very clear to our audience, what are the ways the type 2 diabetes in the young in our population differs?
So once again, sir, we know the concept of thrifty phenotype and the thrifty genotype. So genetically, we are destined to have a metabolic syndrome or even type 2 diabetes. Now, once again, the disease onset is earlier, about a decade earlier from the Western populations. The complications, if you look at the complications, majority, about 30-50% of Indians with type 2 diabetes have some kind of complications on the day of diagnosis of diabetes. The progression of the disease is pretty fast. We have seen individuals with clear-cut garden variety of type 2 diabetes with young onset requiring insulin so fast, maybe after 2 to 3 years of diagnosis of diabetes, they are insulin dependent. They are non-obese, they are lean, but despite being that body habitus, they have significant amount of central adiposity, the visceral adiposity. This is the issues which probably we cannot, these are non-modifiable issues, right? So what we can do is that we can focus, we are basically a high carb diet individual. So we have to cut down that carbohydrate content. And what I have heard you many a times in the past, you have always focused on the importance of the physical activity, right? I can remember one of your talk in one of the meetings in Kolkata. So that's, that was your way of highlighting on the importance of physical activity. So that is important. We have to focus on physical activity. We have to cut down the curve. We have to hit early, hit hard, and we have to monitor for.
Very, very well said. Partha, I have got one important question to ask you. In India, in the diabetes in the young, type 2 diabetes in the young children, adolescents, obese adolescent males and female boys and girls is becoming a great problem. What's your thoughts on the type 2
Right.
diabetes in the young in India?
The youngest patient with type 2 diabetes I recently saw was around 6. All of them are obese.
Absolutely correct. They're
Sorry,
obese children. Absolutely correct.
So these are obese. So once again, we have to highlight upon the avoidance of the high calorie foods and the importance of physical activity. So that's the way to look at it.
Do you also feel, Dr. Partho, that the description, there is a diabetes in the young registry of India, Government of India, which I chair, and we have recently harmonized, we call it harmonizing our data with the search, ACR-CH of the United States of diabetes in the young. And, we find that our diabetes in the young data almost corresponds to the diabetes in the young in the United States. And in the realm of obesity, of junk food eating, no activity, and etc. etc. I just wanted to ask you that we have given the name to this type 2 diabetes in the obese children in India as malignant diabetes because they develop complications fast, and you say they need insulin much earlier. What is the message you like to give to this type 2 diabetes in the young population? Number one, for the management, and number two, the general public of India today about its total prevention.
So once again, sir, the message would be for the parents, because it's very difficult to counsel those children at your clinic. So the message would be for the parents. Don't focus too much on, study is important, study is important, but majority of those, they do not play, they don't go outside, they are stuck to their table working on laptops, mobile phones. So please try to avoid them. Give them some time for physical exercise. There is no alternate to physical exercise.
Absolutely.
And once again, avoid all the junk foods, the fast foods as far as possible. I do understand their emotions. It's very difficult, to deny those cute little children to whatever they ask for. But once again, at certain point of times, they have to be a bit strict. And for management part is concerned, I think for those children, metformin plays a significant role. They are obese, they have significant acanthosis nigricans. So give metformin at the full possible dose, the full tolerated dose. I have seen trained physicians treating those children with dozens of insulin, so lots of insulin. Despite that, they have uncontrolled hyperglycemia simply because the underlying insulin resistance has not been taken care of. So look for the clinical features of insulin resistance, add metformin to the fullest possible tolerated dose, and then you add other agents. There is no harm if you add insulin. There is no harm even if you use sulfonylurea as an off-label drug in those agents. But try to focus on the underlying insulin resistance in those children.
I think very, very well said. Dr. Partho, as you rightly said, we found in our registry about 64% are type 1 diabetic in the types of diabetes in the young, and 26%, almost little more than 1/4, are this type 2 diabetes in the young. And the bottom line of the management is absolutely correct: metformin, and of course with diet and the physical activity. Very beautifully said. I just wanted to ask you, Partho, what are your takes on the weight neutrality or weight losing potential of the other two drugs that we discussed today? One is the GLP, or let us see only oral gliptins, and also the SGLT2 inhibitors. What do you think about the weight losing or weight neutrality potential?
Sir, the available anti-diabetic agents can be classified into 3 groups as far as the weight part is concerned. Number 1, those who are associated with weight gain. For an example, the sulfonylureas, the glinides, the glitazones, and the insulin, right? There are agents who are weight reducing agents like SGLT2 inhibitors and the GLP-1 receptor agonists. And there are agents which are weight neutral. For an example, metformin, the gliptins, and the AGIs. Having said that, I have seen a significant number of people who are on metformin and gliptins losing significant amount of weight. But despite that, I would classify them as weight neutral agents, right? So once again, it all depends upon the diabetic treatment. It has to be, individualized. For an example, those who are lean or having a lower BMI, pioglitazone is a good choice. It's underutilized, but believe me, it's a wonderful drug. It can do magics in some of our patients. Similarly, for those who are obese, I try to avoid glitazones. For them, my GLP-1 receptor agonist is the costly affair. So majority of our patients cannot afford a GLP-1 receptor agonist. So SGLT2 inhibitors, metformin, and the gliptins would be the best bet for those patients. Having said that, in my practice, associated with SGLT2 inhibitors, perhaps is not sustainable. Majority at 6 months or 1 year of SGLT2 inhibitor therapy. I do not know the reasons. I do not know whether the lifestyle, the foods, etc. are coming into play. But I have seen the weight losing property of SGLT2 inhibitor probably is not sustainable in about 1/3 of our patients.
I think wonderfully you have summarized everything, Dr. Partho. SGLT2 some time back was not affordable, but today, as I told you, it is affordable, appropriate, available, and accessible across the pan India. Number 2, as you rightly said, the weight loss potential is almost 1.5 kg to 2 kg, properly treated, or even little more. When it is combined with the other weight losing or weight neutral drugs, it can go even up to 2.5. Third point, you have beautifully said that that when we give metformin with gliptin, even both are weight neutral, there is the exhibition of some good amount of weight loss. So that type of opportunity one should not lose. Before I close, Partho, I have to ask you three questions. Number one, in the current therapy, how will you position the drugs, the newer drugs like SGLT2 inhibitors and gliptins vis-a-vis metformin and sulfonylurea?
So metformin, frankly speaking, metformin is the drug I trust. It's a drug which is close to my heart.
Partho, I have called it the foundational drug. The foundational
Exactly, sir.
drug, metformin will remain so. I 100% agree with you. Next.
Majority of my patients, at least 95% of them are on 2 grams of metformin, the fullest possible dose if that can be tolerated, right? Now, once again, if there is established atherosclerotic cardiovascular disease or a heart failure, particularly despite having the recent data I am quoting that even if particularly if the ejection fraction is less than 40 or there is an established CKD, there is no doubt that you choose SGLT2 inhibitors or a GLP-1 receptor agonist. There is no doubt about that. Now, once again, sulfonylurea, in my personal opinion, would stay in India.
I think, Partho, 1 minute, I cannot agree more with you. Because the sulfonylurea also, as you rightly said, is provided free of cost in the all central government NCD clinics. We provide metformin, we provide glimepiride. We have taken out the glibenclamide, we provide glimepiride because they agreed to come under the price control. They become also very affordable. And this combination in India, you know what is the largest selling combination today, Partho? It is the metformin plus glimepiride. And you know, that's number one issue. The second thing I would like to tell you, I'll reiterate what you already said. You know, in Indian market, the combination therapies do wonders because of their convenience, compliance, and the cost. So I think they have come to stay. Before I close, I'll like to know your ideas about this combination therapy, 2-drug combination that we have today. I'll dictate them with the names. Number one, metformin sulfonylurea. As you said, largest selling combination, still relevance to our country. Metformin with the gliptin, one of the best combinations after the verified trial and has glycemic durability and efficacy. Third is the combination of the SGLT2 inhibitors plus gliptins, which I've got addressed about 7 out of 8 ominous octet. Last question is, how do you think the market, not only market, the acceptability, the need, the real hardcore prescription for the metformin plus gliptin plus SGLT2 in our country? And before I close, I must add you, in many countries in the world, these 3 combination therapy, not in single pill, but separately, given by people like Difronjo, like Paresh Dandona, they have said they have taken away the complicated diabetes. What's your feeling about this triple drug combination?
It's a wonderful combination. There is no doubt about that. And what is even more important is that it can significantly reduce the pill burden. You give a full dose combination of a gliptin and flogin and metformin in one pill, and one pill containing a glimepiride and another dose of metformin. So 2 pills, you address all arms of different amino octet. That's it, done and dusted.
Absolutely.
So the take-home message would be to overcome the barriers of management of type 2 diabetes in India would be number one, it's a lifelong disease. So we have to teach not only the patient, but also his or her relatives regarding comprehensive diabetes care. That is number one. And number two, as I have already told, India is harboring the second largest population of type 2 diabetes in the world. So we have to have more trained physicians who are willing to offer comprehensive diabetes care at the population level. Right? It's not that many of us endocrinologists who are working in tertiary care hospitals,
So we need more trained physicians willing to work at the grassroots level. Now, once again, the importance of early intensive control cannot be overemphasized. So we need to treat them early and treat them hard. Now we have agents which are more of anti-hyperglycemic agents than hypoglycemic agents, and now we have data to show that early combinations of a gliptin and metformin, as early as individuals with A1C of 6.5, can prolong or can delay the initiation of a third agent. Now, there are different aspects of pathophysiology of type 2 diabetes, so we have to address all the possible arms of differentious amino octet. Once again, there is a need to combining agents targeting a different arms of differentious amino octet. The regime has to be simplified as because it's a lifelong disease. As of now, there is no cure for type 2 diabetes. So all of those, they need to take drugs for the rest of their life. We have to offer a simplified regime as far as possible. If you can remember the etiologies of non-compliance, one of the major contributors was cost and the other was pill burden. So we have to reduce the treatment cost. We have to reduce the pill burden by offering a fixed dose combinations. And once again, they need to be monitored at least yearly if everything goes well. If not, every 3 to 6 monthly. We need to look upon not only the glycemic status, but also on the renal functions, the lipid profiles, and of course, the retinal and the nerve issues. That would be my take-home message.
I think, Dr. Partho, it was great having you with us. Your messages to the public has been great, simple, and the greatest truths in the world, Partho, as you rightly said, are simplest. So in your simple message, you have spoken to us about the issues of type 2 diabetes. In about 8 or 9 slides, you give beautifully the entire panoramic view of the Indian diabetics challenges. Not only you showed the challenges, you also gave the solutions. Even though I took 1 or 2 questions from there, I took my course in different tangent because those are very clearly said. Dear Dr. Partho, I thank you profusely for your time, your love, and your passion to speak to us regarding the diabetes in India and the challenges. We'll meet again. Thank you very much. Bye-bye.
Thank you so much. Thank you so much.